Assalamu alaikum. Now I would like to discuss about beta blocker toxicity. Beta blocker toxicity. Symptom onset 2 to 6 hours after ingestion. Signs and symptoms there may be hypotension, bradycardia, bronchospasm. Hypotension, bradycardia, bronchospasm, altered mental status, and seizures. Beta blocker can cause bradycardia, hypotension, bronchospasm, altered mental status, seizure. On labs, there may be hypoglycemia. ECG may shows PR prolong and bradycardia. ECG shows PR prolongation and bradycardia. Okay, management secure airway, GI decontamination, IV fluid bolus, IV atropine, and glucagon because it causes hypoglycemia. You need glucagon. Beta blocker toxicity. Excessive adrenergic blockade decrease intracellular cyclic AMP, decrease intracellular cyclic AMP, beta blockade mediated effects, cardiac suppression with bradycardia and hypertension, cardiac suppression with bradycardia and hypertension. There may be confusion due to cerebral hypoperfusion, confusion due to cerebral hypoperfusion. Beta blockade mediated effect, bronchospasm, hypoglycemia, confusion, seizure due to hypoglycemia. Bronchospasm, hypoglycemia, confusion, and seizure due to hypoglycemia. Diagnosis: ECG shows sinus node dysfunction, AV block, consistent clinical presentation, drug levels not useful here. Treatment is IV fluid for hypertension, atropine for bradycardia, glucagon for hypoglycemia to direct counteract toxicity of intracellular to direct counteract toxicity of increased intracellular cyclic AMP, and calcium gluconate sometimes given to increase blood pressure, sometimes given to increase blood pressure. Calcium gluconate sometimes given to increase blood pressure. So very high yield calcium gluconate can be given to increase blood pressure, not in normal condition, in beta blocker toxicity. Beta 1 blockade mediated effects are predominant with cardioselective beta blocker metoprolol, whereas all effects are seen with non selective beta blocker like propanolol. Lipid soluble beta blockers, propanolol, can also cause confusion, seizures via direct CNS toxicity. Treatment secured the airway, give isotonic fluid bolus and IV atropine for initial treatment of hypotension and bradycardia in patients with refractory or profound hypotension. The next step, refractory and profound hypertension, next step is to give IV glucagon. Other therapies can be used simultaneously in succession of IV calcium gluconate, IV calcium, catecholamine vasopressor, IV calcium, catecholamine vasopressor, epinephrine or norepinephrine, high dose insulin or glucose, and IV lipid emulsion therapy used to manage poisoning in lipophilic medications such as beta blockers. Okay, now our next topic is lithium toxicity. Lithium, the mnemonic says it all. Lithium, low thyroid, Lithium, that means there is low thyroid, unwanted movement, and in lithium there is insipidus, there may be diabetes insipidus. In acute toxicity, intentional overuse, chronic toxicity, decreased renal perfusion, decreased lithium clearance, there may be dehydration, thiazide diuretics, NSAID use, and AC inhibitors, decreased renal perfusion due to thiazide diuretics, NSAIDs, and AC inhibitors. Acute toxicity, gastrointestinal nausea, vomiting, diarrhea, late a neurologic sequel. Chronic toxicity, neurologic lethargy, confusion, agitation, ataxia, tremor, fasciculation, seizure. IV hydration and hemodialysis should be done. IV hydration and hemodialysis should be done. So, lithium toxicity, it may be intentional overuse, it may be chronic toxicity, decreased renal perfusion. So, this is all about beta blocker toxicity. This is all about beta blocker toxicity and lithium toxicity. Hope you enjoyed.